Good afternoon. My name is Sid Padia. I'm an interventional radiologist at UCLA, and I'm going to be talking today about minimally invasive treatments for liver cancer. To make an appointment with UCLA Interventional Radiology, these are the phone numbers that are posted. Now, an interventional radiologist is a physician who performs minimally invasive procedures using imaging guidance such as X-ray, ultrasound, or even CT. And you can also ask questions on Twitter or on Facebook using this hashtag. Now, as a brief introduction, there are two forms of liver cancer. You can have primary liver cancer. That is tumors that start within your liver. The most common of these are hepatocellular carcinoma. A minority of them can be something called cholangiocarcinoma. Most people who present with liver cancer have secondary liver cancer. That means it metastasized from another original site. And the most common sites are someone with colon cancer, which has metastasized to the liver, or breast cancer, or neuroendocrine tumors. And this represents by far the majority of people who do present with liver cancer. Now, in terms of primary liver cancer, that is tumors that start within the liver themselves, there are multiple causes, and the most common causes in the United States are hepatitis C and hepatitis B, as well as people who have long-standing chronic heavy alcohol use. Now, the challenge is that hepatocellular carcinoma is challenging to treat. There are multiple different treatment options, but these are overall relatively complex, and I'm going to go through a few of them today. Worldwide, you can see that the United States, in terms of prevalence for liver cancer, is somewhere in between. And you can see that in Asian countries such as China, South Korea, and Japan, the incidence of liver cancer is far, far higher. However, due to the rise of hepatitis C in the 1970s and 1980s, before testing was widely available, these patients manifested in liver cancer 20 to 30 years after they got hepatitis C. So now what we're seeing is an increase in prevalence of liver cancer over the last 10 years, which is projected to continue over the next 10 to 15 years. Now, the reason that this is a challenging condition to treat is that patients can present in various different stages. For example, here you have 4 different scans of 4 different patients with widely different tumor biologies. So for example, on the top left, you have a tumor, a single focal tumor in the back of the liver, but on the bottom right, you have multiple tumors occupying almost the entire liver. And you can imagine that the prognosis for these 2 patients and the treatment options are very different. Now, in terms of treatment options, there are several, and this ranges from aggressive to something like liver transplantation or surgical resection, to relatively conservative and non-invasive things like supportive care or systemic chemotherapy. And how do we decide on treatments is largely based on the tumor size, tumor number, where the tumors are located, if the cancer is spread outside the liver, the other medical conditions that someone may have, such as heart disease, lung disease, a stroke, etc. But most importantly, this involves an in-depth conversation between the patient who has liver cancer and us to determine what are the best goals and what are and how aggressive or how non-aggressive does a patient want to be. Now, in terms of the treatment options, I'm going to discuss the 3 main treatment options in terms of minimally invasive treatments. That includes thermal ablation, chemoembolization, and Y90 radioembolization. So the first one is localized ablation, and you can see a bunch of acronyms here, and I'm going to discuss specifically the radiofrequency and microwave ablations. These are thermal ablation technologies. Now, a thermal ablation is, the way this procedure is performed is done under anesthesia, so that the person's asleep during the procedure. A thin needle, it's about the size of a pen tip, is inserted right through the skin into the tumor, and we use an ultrasound or we use an X-ray to look where we're going, so it's completely minimally invasive in this case. From the tip of the needle, there's heat that's emitted, and the tumor essentially cooks to well above 150 to 200 degrees for about 10 to 15 minutes. After the cooking is done, the needle is removed, a Band-Aid is applied, patient's woken up from anesthesia and sent home. So overall, the procedure is relatively quick and painless. This is an example of one of the thermal ablation devices. You can see a bunch of tines coming out of the main needle, and this is to increase the ablation zone or the heat zone so we can even treat larger tumors. This is an example of a patient where we did under CT guidance. So keep in mind that there's no large incision that's done in this. This is simply a poke right through the skin. So again, under anesthesia, we numb up the skin and insert this probe into this tumor right here in the back of the liver. And you can see on the bottom right image that the tines of the needle are deployed to get a bigger heat zone covering the entire tumor. This is a different patient who had a single focal tumor right here in the liver, this oval bright spot. And 1 month after a thermal ablation, it's completely dark. And that means a dark tumor is a dead tumor. So the ablation results in the right setting work extremely well, and this has become kind of a first-line therapy for us in patients with small tumors. In fact, we can achieve complete kill in greater than 9 in every 10 tumors that we treat. Now, there are certain limitations to this technology. Number one is the tumor size. Once we start getting bigger than an inch or so, this technology does not seem to work as well. There are certain locations in the liver where thermal ablation may not be safe. And finally, in patients with multiple tumors, let's say you have 4 or 5, this becomes relatively unfeasible to do. And that's where it lends itself into other technologies which are kind of in a group called arterial embolization. The two main procedures that we perform in this group are called chemoembolization and Y90 radioembolization. Now, these are minimally invasive procedures where the therapy is given through the blood vessels going into the liver. So this can be used for larger tumors, multiple tumors, tumors that are spread throughout the liver, and it's also used in combination. So we can use these technologies in combination with that ablation technology, which I mentioned earlier. It can be used in combination with surgical resection, or it can even be used in combination with liver transplantation. Now, if we imagine that we are injecting a bunch of particles into the blood vessel going into the liver, it'll spread out throughout the liver in kind of a even distribution. What happens when we have a tumor in the liver, the tumor sucks up all the blood in the liver. And so when we inject when we inject particles in the blood vessel going into the liver, they preferentially seed into the tumor, and then there's less of these particles that deposit in the remainder of the normal, healthy liver. So what is chemoembolization, also known as TACE, or T-A-C-E? Chemoembolization is a localized delivery of chemotherapy agents. So you can imagine that someone who gets chemotherapy the old-fashioned or the standard way, which is through pills or through an IV in their arm, well, the medication goes throughout their body from head to toe. So you feel all those typical side effects of hair loss, nausea, vomiting, weight loss, etc. This is a localized delivery of chemotherapy, so all the chemotherapy goes completely into the liver and most of it goes into the tumor. As a result, there's very little amounts that go into the rest of your circulation. When we give the chemotherapy, we also give it coated on a particle. And so what these particles do, which look like essentially like grains of sand, they essentially block off the blood supply going into the tumors. So the tumors need blood to feed itself, to get nutrients. By delivering these particles and essentially choking off the tumors, we're essentially starving the tumors of any nutrients. And so these cancers die by two ways. One is by the chemo effect, and the second is by starvation. So this is all done through an angiogram. An angiogram is a minimally invasive procedure. It's performed as an outpatient. So the person is sedated through an IV in their hand, so they're given medications to make them nice and sleepy and groggy. This is also known as conscious sedation or twilight sedation. A local anesthetic is applied at the crease of their leg. And then a small plastic catheter, it's about the size of a tip of a pen, is inserted into the blood vessel at the crease of the leg. It's completely painless. There's just a very minimal amount of discomfort. And the rest of the catheter is guided into the blood vessels, into the liver. It's done using X-ray guidance, so the person undergoing this procedure, it doesn't feel it at all whatsoever. Keep in mind there's no large incision done for this. At the end of the procedure, simply a Band-Aid is applied at the incision site. So this is an example of an angiogram. You could see this plastic catheter on the left side of the screen. And the black outline represents the contrast dye that someone might undergo when they get a CAT scan. And you could see this dark ball that represents a tumor that's sucking up all the contrast dye. And again, this is done through a catheter that's the size of a tip of a pen through the incision at the crease of their leg. This is an example of a patient with 2 tumors kind of in the front of their liver, which you can see here by the arrows. And you can notice that they're slightly bright. That means they take up the contrast dye, and that means they're still living. After a chemoembolization, you'll notice that this one here has completely died, and that's why there's a dark spot. And the other one has died probably about 70 to 80%, and only with a small amount of viable tumor left. And that patient underwent a second round of chemoembolization with a very good result. There are some side effects to the procedure. Most people will get something called a post-embolization syndrome. This is essentially like having the flu for about 3 to anywhere up to 7 days, consisting of fatigue, a little bit of nausea, sometimes fever, some aches and pains, but it goes away after a week. There are some more rare complications like getting an infection or liver failure. These happen in well less than 1 in 100 patients. Now, the other arterial-directed procedure is something that we specialize here in at UCLA, and that's called yttrium-90 or Y90 radioembolization. This is the same concept, except this is a radioactive procedure where we inject very small particles containing a radioactive element. The radioactive element is called yttrium-90, also known as Y90. So this radioactive element is embedded inside these glass particles, which are then injected into the blood vessel feeding the tumors. And you can see on this photograph, this is a photograph of a human hair, and you can see all the particles lodged right next to a human hair, showing how small these particles are. So even in a glass vial, which you can see on the right, you can essentially not even see these particles. Now again, these are administered through a catheter in the hepatic artery, or the artery going into the liver. It is targeted internal radiation, so the radiation comes from the inside of the tumor, as they're trapped inside the small blood vessels inside the cancer. So when someone gets conventional radiation, they get X-rays or some kind of radiation form shining in from the outside of their body inwards. In contrast, Y90 radioembolization is a procedure where the radiation is essentially deposited inside the tumor and it radiates outwards. And as a result, we can give potentially much higher doses of radiation, which will kill cancers and minimize the amount of radiation that goes into the rest of the body. The way this works is this is done through, first we perform an in-office consultation, discussing the pros and cons of this procedure to make sure that it's appropriate. There's an initial planning procedure. Again, this is an angiogram. It's an outpatient performed in the hospital, again with the twilight or conscious sedation through an IV. It's an angiogram performed through that small catheter at the fold of the leg. It's almost completely painless. The procedure lasts about 1 to 2 hours, where we take pictures of the liver blood vessels to make sure that they're feeding arteries going into the tumor. After the procedure is done, the patient goes home. We order the Y90 particles. This is a custom make order, so a company makes it specifically for each individual. They ship it out, and we bring the patient back in 1 to 2 weeks for treatment. The treatment is the same procedure, outpatient, performed with sedation, at the crease of the leg with a small catheter, which is completely painless. And again, the procedure takes about 1 to 2 hours. Again, we saw this picture initially, and this was an angiogram 6 months later on the right, where you could see essentially all the blood vessels that are lit up by the contrast dye, but the tumor has completely disappeared after treatment. This is a person who had much more extensive tumor. You can see this infiltrative bright spot along the about half the liver, and it also invaded into the blood vessels into her liver, so she had a very, very limited prognosis before we started treatment. We performed an angiogram. You can see this catheter going from the bottom of the screen up in her aorta and then going out into the right side of her liver with the tumor lit up with that kind of gray cloudburst pattern. We deployed the Y90 radioactive microspheres from this location, and this required a single procedure to treat her entire tumor. And this is her 2 years later, where she has just a small amount of what's called necrosis or dead tumor, no viable tumor after a single procedure that lasted well over 2 years. This is a different patient. The images are slightly grainy, but you can see a focal area, just a little bright in the back of the liver. It had also invaded into the blood vessels going centrally, right here. And again, this is the angiogram of the right side of her liver. And you can see this dark area where her tumor is, and then the images after the Y90 microsphere deposition showing a concentrated yellow area where the radiation occurred. And this is her initial scan, and at 2 years, not only does she have complete disappearance of the tumor, the normal liver actually grew back in its spot, so it's like the images appear as if she never had cancer to even begin with. Now, there are some side effects from this procedure as well. Most people will feel some degree of fatigue. The fatigue is generally mild, but it can last for anywhere up to 2 to even 4 weeks. People will return back to their normal energy level after about a month. Some people will get some mild abdominal pain or discomfort, which usually lasts for 1 or 2 days, and then it goes away. There are some more uncommon side effects, such as getting an ulcer or getting liver failure. These are extraordinarily rare, occurring in well less than 1% of people who get treated with this technology. Now, in comparison, when we compare the Y90 microsphere radioembolization to the chemoembolization, they both work relatively well. There are some pros and cons to each of the procedures. For example, the side effects tend to be mild for both. The chemoembolization in general requires a single overnight hospitalization, whereas the Y90 radioembolization is done strictly as an outpatient procedure where people go home 2 to 3 hours after the completion. Y90 and TACE, or chemoembolization, both work in the primary liver cancer, also known as hepatocellular carcinoma, whereas Y90 tends to have a better benefit in those secondary liver cancers known as metastatic disease. So if you have a colorectal cancer that is metastasized to your liver, the Y90 radioembolization tends to have better results. When we talk about the stages, early stage, intermediate stage, advanced stage, the Y90 radioembolization tends to work better in the early stage. Chemoembolization may work better in the intermediate stage. Y90 may work better in the advanced stage. And again, for metastatic disease, Y90 tends to work better. So what we do is we evaluate each patient and figure out what is the best therapy for them when they come in for an in-office consultation. As an example, we compared the early stage patients in over 200 people who underwent both of these procedures, the Y90 procedure versus chemoembolization. And the key thing to point out is the complete response rate. That means how many of these people got 100% tumor kill. And in 92% of the Y90 group, in over 9 out of 10 patients, we got a complete kill of their tumors, essentially a curative intent. Now, in conclusion, there are multiple different approaches to the patient with liver cancer. The choice of treatment really depends on their tumor size and distribution, as well as the preference of the patient who is undergoing these procedures. This, keep in mind, at UCLA requires a multidisciplinary team. We have absolutely fantastic transplant surgeons, surgical oncologists, medical oncologists, hepatologists, and we come together as a team to come up with the best consensus treatment options for each individual undergoing treatment. And for that, I want to thank you for your time. If you have any questions down the future, feel free to reach us for an in-office consultation, which you can reach us with these contact numbers listed here on the screen. And it looks like we have questions from Twitter and Facebook. So the first question is, I have breast cancer that has metastasized to my liver. I'm concerned about undergoing chemotherapy, which is what my oncologist has recommended. Could this be a better option? So that's an excellent question, something that we encounter at least several times a week. Patients are understandably concerned about chemotherapy. In general, chemotherapy is considered the first-line therapy for anyone who has metastatic tumors. And this is often used in conjunction or with chemotherapy. Furthermore, it can also be used down the road. So most people will try chemotherapy first, and if they don't tolerate it or if it doesn't work, then this can be considered. But in general, chemotherapy is still often considered the first-line treatment for people with metastatic tumors to the liver. Another question, do insurance companies cover these treatments, or are they experimental? So these were experimental way back when. The Y90 radioembolization procedure has now been around for about 20 years. All these procedures that I've talked about today are listed in all the national cancer guidelines, and they are approved by almost every single insurance company in the United States. So these are all approved procedures that we have extensive experience with in various different tumor types. And with that, I'm going to Thank you for your attention. Thank you for listening, and have a nice day.